Dear Pure Urology viewers, good evening, one and all. Today, we are discussing a different topic, not stone, not prostate, but something which most of us uh, see this type of patient with chronic testicular pain. Sometimes it is post hernia repair, sometimes it is post hydrocele repair, then it is acceptable. Sometimes without any reason, without varicocele, patient will having chronic arcalgia. These are the patients who use diclofenac, tramadol, tryptomar, gabapentin, etc. And they will be roaming with a lot of medicines and tight underwear also. At one point, I used to think that by giving lignocaine injection intermittently, it can reduce, but it did not work out also. So I am also curious about this topic when one of my friend Yogesh Kaje suggested Dr. Irfan Shaikh uh, about the denervation of the nerves of the scrotum and testis, and predominantly testis, through the inguinal canal. Obviously, this has to be done with microscope. To talk about it, I have less knowledge about this. I will share the screen to introduce the speaker, and then we will give uh, the over to Dr. Irfan Shaikh. So today, microsurgical denervation of spermatic cord for chronic testicular pain by Dr. Irfan Shaikh, who is consultant urologist and neurosurgeon with MBBS, MS and MCH urology, MBBS from BJ Medical College, Pune, which is well-known medical college, MS from PGI Chandigarh 2008 to 2011, MCH urology from Nair Hospital, Mumbai 2012 to 2015, secured first rank in MCH University exam, senior clinical fellow urology at Lister Hospital, Stevenage, UK, trained under Dr. Park, Seoul, Korea for penile prosthesis, special interest in men's health, started Urolife store and men's clinic in Pune presently. So with this introduction, I will hand over this something interesting topic to Dr. Irfan. Dr. Irfan, thank you very much for joining. Take your own time. No need to think about the time. Slowly
Yes,
you present so that it will be a good document.
yes, sir.
Thank you. Over to you.
Thank you, sir. Thank you for giving me opportunity to speak on this big forum, Pure Urology, to share whatever knowledge I have regarding treatment of chronic testicular pain. So I'll be sharing the screen. So we will be discussing basically the clinical presentation, how to select patient, what investigations are required, and most importantly, the surgical technique, how we can
Correct.
go ahead for surgery. So I'll share the screen.
Yeah, your screen is visible clearly.
Yeah,
Your
yes, sir.
voice
Yes,
is also clear.
yes, sir. Thank you.
Yes.
So first of all, orchialgia. So orchialgia is a term. More scientific term is chronic scrotal content pain. Basically, orchialgia implies the pain in testes only, but generally all of us must be aware that this pain mainly comes from epididymis or paratesticular structure. Sometimes pain is originating in spermatic cord also. So more scientific term is chronic scrotal content pain. uh, so when do we call any patient who is coming with testicular pain or scrotal pain is having uh, chronic orchialgia? So the time duration definition is one who is having intermittent or continuous testicular pain or scrotal pain which lasting more than 3 months, and more important than that is it significantly interferes the daily activities or daily routine of that patient. So this is the definition of it. Unfortunately, like all of us in urology are fond of guidelines like European Urology Guidelines, AUA guidelines. Unfortunately, we don't have uh, any guidelines to guide us how to treat this patient. So basically, mm, uh, we need to know why treating orchialgia is important. All of us see many patients, as Sir said, patients keep roaming from one urologist to another urologist or one specialist to another specialist without having much relief. It like someone has done a study, and it was found that chronic testicular pain, it is a presenting factor in urology outpatient clinics in 2.5 to 5% of patients. It affects the quality of life, it affects the sexual life of the person, and mainly we must be aware that these are the young patients, the patients who are working productive, so eventually it leads to affecting all the family also. So this is very important to diagnose and treat the patients who are having idiopathic chronic orchialgia. This is basically, as we have seen, testicular pain more than 3 months duration. If it is less than that, we should not label it as chronic orchialgia or idiopathic chronic orchialgia. And as I have mentioned, the pain which interferes with daily routine activities, then only the definition is met for chronic orchialgia. We should take thorough history, perform clinical examination, and try to find out underlying conditions such as varicocele, hydrocele, any previous surgery like hernia, history of vasectomy. So these are to be excluded in this idiopathic chronic orchialgia. Those like history of any infection, so those are to be treated first, and along with clinical examination and history, basically ultrasound, scrotum. Along with that, if patient is having history of stone disease, then it could be mid-ureteric or lower ureteric stone, which can present as a pain in scrotum. So basic ultrasound scan of the abdomen is also required. And when all these criteria, like or all these diagnoses are excluded, it meets the definition for chronic orchialgia. So as I told you, physical examination is very important. Along with that, DRE to rule out prostatitis, scrotal ultrasound to identify any other possible causes of chronic pain, such as epididymochitis, any presence of varicocele, any other like condition which can produce intermittent pain, such as intermittent torsion. They are to be uh, excluded completely. Any form of upper tract imaging is very important. Along with that, uroflowmetry. I also do uroflowmetry for all of these patients, because many of these patients nowadays we are seeing lot of young patients coming with very poor flow. Along with that, they have testicular pain, erectile dysfunction. So basically, this is a common symptom complex of non-relaxing pelvic floor muscles. So these patients are also sometimes present with one of these symptoms, and if we don't evaluate them properly, then we may tend to miss out on other diagnosis. In 2018, like chronic, as I told you, there are no specific definition, no specific guidelines. So in 2018, uh, multicentric study was done, and the study outcome was for diagnosing chronic orchialgia. They have come up with chronic orchialgia symptom index. Basically, uh, 12 questions are selected, which were found to be very common among these patients, which will depend on the characteristics of the pain, the sexual symptoms which are bothering the patient, and quality of life. Based on that, scoring system was devised, and basic like this is what people are using to know the outcome after the surgery, and to diagnose patients which are having chronic orchialgia apart from the other diagnosis. So basically, these are less clinically relevant, but more for uh, like, measuring the response to treatment based pain pointers were main important pointers were like how like what was your minimum pain in past week. So 5 is the worst pain and 0 is none. Average pain you are experiencing in past 1 week. So 5 is the worst pain, and how often you have pain. So the people who are having pain always, they will be rated as 3. Again, the sexual questionnaire where do you have erectile dysfunction, do you suffer from low libido, or do you have pain in ejaculation. Based on these, they will be scored. And quality of life questionnaire were 3 questions. One will be, does it interfere with your work? Another one would be, does it interfere with your leisure activities? And the next one would be, uh, will you be okay if same pain is being like you will be experiencing similar pain for rest of your life? Will it be okay for you? So patients were given score based on this, and total score, the maximum score could be 37. Out of this, what I have no, found out that the most important question is it affecting your work or your leisure? Because pain perception abilities of different individuals could be different. But if the pain is interfering with the day-to-day life or interfering with his leisure activities, they are very important. And these are the most important pointers where we decide should we go ahead with surgical treatment or not. So this is the treatment algorithm for chronic orchialgia patient. Uh, Ideally, for all patients, conservative treatment is to be uh, tried. I tried for 4 to 6 weeks, where patients are given non-steroidal and NSAIDs, antibiotics, mainly the fluoroquinolones, which have better penetration for testicular and epididymal infections, anxiolytic, tryptomer, or I don't prefer it, but if patients don't respond at all after NSAID antibiotics, I add gabapentin for those patients to see if that helps. Uh, uh, History of vasectomy is very important, but very rarely nowadays we are seeing patients who are having vasectomy. Post vasectomy pain is doesn't respond to any of the conservative measures, and sometimes we should have to think about vasectomy reversal also in these patients. If like patients are not responding to the conservative management, then we should think about the surgical management. In this, spermatic cord block is one of the way which will tell you that whether patients will be responding to the denervation or not. Many times, patients, they are not ready to accept a surgical solution, and most of the time when they visit other specialists or other urologists, many of them are discouraging or not aware about the surgical treatment. So for us to convince patient, spermatic cord block can be a good option, where uh, we explain to them that this can relieve your pain temporarily, and if your pain is relieved even for a day or so, even 50% of the pain is relieved, there are good chances that post denervation your pain would go. So that is, rather than like treatment algorithm, I consider it as a way to convince patient that this can work. So spermatic cord block, and then denervation, which could be done by multiple ways. I'll be coming up with that in my uh, presentation. So we like this is we all of us have done multiple varicocele right from our general surgery days to microsurgical varicocelectomy in our urology days. So, what is the anatomical basis of this surgery, and what is different than what we generally do in varicocelectomy? So, we should understand like a study was done in patients who underwent radical orchidectomy for cancer, and the spermatic cord content was evaluated, and it was found that spermatic cord contains uh, minimum multiple small less than 1 millimeter nerve fibers. The median number of nerves were found to be 25, and the examination of patients who had chronic orchialgia, it was revealed that 84% patients had Wallerian degeneration of these nerves, and that is the main pathophysiological feature which is currently believed to be the cause of orchialgia, where in spite of like the initial insult, it could be infection, it could be trauma, it could be multiple things. Even in spite of the insult being gone, patients they continue to feel pain because of the Wallerian degeneration. It leads to hyperesthesia, paresthesia, and eventually leading to chronic testicular pain. So these studies showed that there were three primary locations for the nerve plexuses, and where maximum changes were observed. First is cremaster muscle fibers. Second one is the perivasal tissue and vasal sheath, and the fibrofatty tissue within the spermatic cord. These were the three regions where maximum number of nerves were found. So, I'll be explaining the procedure to do spermatic cord block. I don't consider it as a therapeutic thing. It may be a diagnostic thing, or maybe a way to build confidence in your patient, where they have the understanding that my pain could be relieved, because most of the patients, they are, because of the chronic pain, they are depressed, or many of patients, they tell me that like I've lost all my hope and I don't believe that this could be done. So in those patients who are skeptical about results, it is always better to do spermatic cord block. As I told you, it is a predictor of post-operative pain relief after surgery. In this 50 total 32 ml of mixture is created, where 15 ml of lignocaine, 2%, 15 ml of 0.25 bupivacaine, and 2 ml of dexamethasone, that is 8 milligram. The trifecta which we discussed, that is the cremaster, vas, and the fibrofatty tissue within the spermatic cord, they are targeted in this. So first, we palpate the spermatic cord and the vas. So vas is particularly palpated at root of scrotum, uh, and within a single prick, we inject 5 ml of this mixture in perivasal tissue. Multiple attempts of injection are to be avoided, because it can damage the artery around the vas, or sometimes direct injection within the vas can also cause fibrosis. So this is one. Ideally, ultrasound guidance is to be used for giving spermatic cord block. Then remaining 25 ml of this mixture is injected at the superficial inguinal ring to target the cremaster and the fibrofatty tissue of spermatic cord. Basically, you fix the cord at superficial ring by one hand, and you inject medially and laterally to the cord to So 8 ml injection is to be given on both sides. This will target the cremaster muscle, and the remaining 8 ml would be injected within the cord. It is advisable to avoid multiple punctures, so as to avoid any like injury to the artery. So this is the spermatic cord block. Uh, when you will consider that yes, spermatic cord block is working. So if patient experiences 50% pain relief, it would be like good enough for evidence for us to go ahead with denervation. Some patients, along with the testicular pain, they may like testicular. It may accompany with hip pain. So along with the spermatic cord block, ileoinguinal nerve block is to be given. It is to be given 2 centimeter below and medial to anterior superior iliac spine, approximately 2 to 3 centimeter depth, and where 5 ml of this mixture is injected. So this is how a spermatic cord block is done. Surgical technique. This is there are two options basically. One is microsurgical denervation of spermatic cord, and now they have come up with targeted microsurgical denervation of spermatic cord. So I'll be uh, telling like these are the requirements, that is basic microsurgical instruments would be required. Operating microscope is must for these patients. I want to stress this point very much, that using loop should not be a sufficient or proper way to treat these patients. Microdoppler helps to identify the arteries. So it is a good way. Papaverin is required sometimes, not always. Like if you have microscope, it is very like once you become experienced, it is not very difficult to find the artery. So basic instruments are required. Microsurgical instruments, whatever you must be doing, AV fistulas, those instruments would be sufficient for you. So supine position, surgery is done in supine position. Low height OT table helps to avoid the fatigue and neck pain to the surgeon. Basically, the OT table which we generally use for laparoscopy is good enough for these microsurgical procedures. Uh, Good to have a setup for recording these microsurgery surgical procedures. Surgeon sits on the same side of the patient. Operating microscope comes from the contralateral sides. Relaxed ergonomic position is very important because like this is not a surgery where we should hurry the procedure, because like patients would be like very depressed because of this pain, and this is the only option or only choice we have or they have left. And I think we should give enough time, not to hurry, and do justice to whatever patients they have kept their belief in us. So this is how a patient is positioned. Operating microscope is coming from the other side. So this is the recording setup. Our the endourological camera is being used here to record the procedure. So mm, we can easily get an attachment where the endourology camera gets attached. Subinguinal, I prefer to do it by doing through subinguinal incision, because we don't need to cut cut any muscle or open the canal. Approximately 1.5 to 2 centimeter incision is good enough to do this procedure. Inguinal procedures have also been described. So this is typically the size of incision. So ergonomic position is very important here. Here you can see the hands of the surgeon. They are resting uh, so that it will avoid the fatigue and mistakes. So mm, relaxed ergonomic positioning is very important for microsurgeries. So cord, we dissect till the cord is being picked up with Babcock forceps and delivered uh, into the incision. Now we can see the cord is already dissected without doing cord is separated without doing much dissection. Ideally, when we should screen with Doppler. Here, I'm screening for any possible arteries which we can locate, so that uh, our no, because what happens once we start dissecting, some of the arteries they go into the spasm, and it is difficult to identify them. So here the main testicular artery seems to be in the middle of the spermatic cord. So in this step, cremaster muscle is being separated. Slow, gentle movements are required. Here, I, we are separating the cremaster muscle, and cremaster muscle is completely cut, so that one point we should always tell our patients that uh, after the surgery, testes may droop uh, uh, and to the level below than the contralateral testicle. If some patients who are very much worried about the drooping of testicle, we can do fixation of testicle also. So preoperative counseling about drooping of testicle is important. So here always we should anticipate the cremasteric artery, and as much as possible try to preserve the cremasteric artery. Here we can see cremastery is being separated. It is being identified, so that we should preserve it. In this image also we can see there's one transparent lymphatic vessel. I think we'll be seeing it further. So we continue the dissection of the cord further. Gentle, slow movements. My typical instrument, I require only two instruments for doing all these microsurgeries. One is bipolar on the right hand, and Jeweller's microscopic forceps on the left. So here, initially we try to locate the artery so that the further dissection becomes easy. Even if there is any bleeding or anything, we don't aggressively cauterize, or don't try to uh, do hurried ligation or cautery for these things. Uh, so bit by bit we progress. Maybe we can start at one end and progress to another end. That is also an approach we should decide based on our personal preferences. So regarding the location of the artery, it could be located in three locations. One is just like we saw, where artery is located superficially and they are very easy to find. Type 2 is where they are present beneath the veins, and sometimes, like very rarely, the artery is deeply buried within the cord, and it takes a lot of time and patience to identify these arteries. So here we can see artery being separated. So the one I'm holding with by monopolar the forceps now is the artery. Now we should be able to appreciate the pulsation within the artery. So this is Then once it is identified, it could be hooked and protected. So here we can hear the
It was going smoothly.
sir, just second. I think there's some issue with my mic. I'll reshare the screen.
No problem. What is the company of the microscope?
So this is like I'm not using Carl Zeiss. It is locally Indian made, sir.
How much it will cost roughly?
Like I took it 5 years back, around 3.5 lakh. It costed.
Maybe around 5 lakhs now.
Must be, sir. Can you see, sir?
Yeah, yeah. Go ahead. This video is over. This is also over.
So this is the sound I wanted to.
Yeah, yeah.
This is the artery being confirmed on Doppler. So this is how a Doppler can help in
You'll see the
identifying.
screen and operate, or you'll see through the microscope.
Sir, I see through the microscope. That is just for the recording purpose, sir. Because the microscope could not record the Doppler sound, so that is why it was used. So veins are dissected. Many patients they have chronic pain along with that varicocele also. So veins are ligated in those patients. Otherwise, veins are spared. Uh, so veins, these are the veins are in this patient. He had varicocele also. So veins are they could be ligated with the ligature or clip or bipolar cautery also can be used. So vas is important point, place where nerves do travel, and clinical examination can show tenderness when we press the vas. So vas is being dissected here. So generally, vas and along with there's a smooth sheath is there, and in that neurovascular bundle of vas, we the vasal artery is very prominent generally. Artery to vas. So artery to vas is being separated here. Apart from during dissection of vas, approximately 2 centimeter area of vas should be denuded completely, and all the structures apart from the artery to vas, they should be ligated. So this is a short clip showing how a lymphatic looks. So this is a transparent. This is a transparent lymphatic being separated. So this is how a final picture. I think this was the denervation which I did last week, you could see lot of transparent lymphatics being spared. This patient had three arteries basically. So the one, this is the one, two, and another one on the extreme end. So total three arteries, one, two, and this is the three, and this is the artery to vas, what I'm holding right now. Vas being denuded for 2 centimeter here. This is the artery to vas. This this one. So after that we close the fascia and reposition the vas and
Is there
close
any
the
way we
next.
can identify the nerve?
Sir, generally these are small, uh,
Thread-like thing.
thread-like, very small
Thread.
fibrofatty tissue. So it is difficult to identify the nerves separately. So that is why we like while operating, our target is to keep the artery, keep the vein. Minimum three lymphatics should be preserved to avoid the very hydrocele, post-operative hydrocele. Apart from that, whatever structure is there, we should either cut it or use bipolar cautery and uh, divide it. So this is like how neatly done denervation looks. We sometimes like nerves are seen, but most like it is not always possible to identify each and every nerve and sever it completely. So all the fibrofatty tissue needs to be separated and divided, so that patient should not uh, suffer post-operative like pain in spite of doing orchialgia, denervation. So this is how it is done. uh, Roughly 70% patients they have very good response, and 10 to 15% patients, their pain reduces, becomes to a bearable level, and approximately 5 to 10% patients, they still have mm, uh, the pain in post-operative period. So in those patients, like salvage options are also there. I think microsurgical denervation is good option. It should be offered to selected patients, and pre-operative evaluation, patient selection is very important. And as I told you, 10% patients don't respond to this also. So salvage therapy has a role. So salvage therapy has like injection of Botox into the cord, which was found to have relief for 2 to 3 months, or cryoablation by intervention radiologists, cryoablation by pain physicians is also an option. And the like newer options are also coming, like laparoscopic or robotic uh, intra-abdominal neurectomy, where ileoinguinal nerve and inferior hypogastric nerves are severed, just like extraperitoneal hernia surgery, where these all veins are all nerves are seen. So in that area of the deep inguinal ring, these nerves are ligated. But post-operatively, patients experience numbness and paresthesia in the scrotal area. So these are to be kept in salvage therapy also. They don't have any role in primary patients.
Good.
Yes, sir.
Ultimately, what microscopic surgeries other than this you do?
Sir, I do like varicoceles very commonly, uh, microsurgical varicocele. Uh, these reconstruction
Can we
surgeries
close
have
the
become.
screen? Can we close
Yes,
the Can we close the screen?
yes, sir, yes, sir, sure. Stop, sure.
Close it.
Yes,
Yeah.
sir. So
So,
reconstructive surgeries have become very rare, sir, because of the IVF. Many patients are not coming from for reconstruction, vasovasostomy and vasoepididymostomy. So few of them I have done, but they are not very commonly done. I think that is the same among all microsurgical surgeons. They are also experiencing the same.
who are the surgeons who does this surgery and you have learned from?
Sir, like I observed Dr. Upin Shah sir for few cases. When I was in UK, I used to like visit UCLH Department of Andrology once a week. So our department did not have an andrology department at that time. So there lot of microsurgeries they do. It is a big department with 5 to 6 like andrologists and exclusive subspecialty department. So they used to do a lot of work there. So that is where
The
my interest.
microscope which you have taken is also working nicely.
Yes, sir. Yes, sir. Yes, yes.
What is the magnification that is achieved? Dr. Chandramohan Godala is asking.
Sir,
5x, how much?
uh, so 10x is sufficient, sir. Maximum they can do up to I think 15 or 20x. But now my initially I used to change the magnification, but now my magnification is set at one particular thing, and I have become comfortable with that. So I don't change it. It is fixed at 10x, and which is sufficient I feel for all
Normally,
type of.
loops have 4x like that. That this will be much bigger than that, na?
Yes, sir. Much more comfortable, sir. Much more comfortable. Now, I've been doing
Which
this since
company you should tell? If it is 3 lakhs, it's not cheap only. Which company it is?
uh,
You don't remember?
sir, this is a local company. In Maharashtra only they are making. I can give you details, sir. I forgot.
Okay. Microscope is from local.
Yes, sir. Yes, sir. Yes.
Because we use only for this surgery, na?
That
So
is the only thing. Yes, sir.
uh,
Yes. Yes, sir.
we don't have any cost effect. If it is 3 to 5 lakhs, we can buy monthly 2, 3 cases chalega. And they are not going to destroy, na? They will be there forever,
Yes, sir.
unlike scopes and monitors. And the
Yes,
other
sir.
question, any nerve stimulator be used to locate? They are too small, I think.
Uh, as I told you, they are less than 1 millimeter nerves. They are not. They are used mainly, sir, for salvage treatments where pain physicians they locate the nerves very proximally and ileoinguinal nerve, genital branch of genitofemoral nerve, and
You are in Pune.
yes, sir.
Any observership somebody is asking, Pratik Verma, I think they can contact you.
Yes, sir. Yes, sir.
कितना cases regularly होते हैं?
Uh, yes, sir. This is now like people have become aware that I am doing these surgeries, so I'm
Yeah, yeah, yeah.
getting referrals. So that is the
Good.
maybe that is the reason, sir.
Very nice. Good. We don't know. Mm, uh, anyway, generally these problems are really annoying. Patient will expect what is the post-operative result? They get good relief.
Sir, like I have seen, like I counsel the patients that like approximately 60-70% patients they experience complete pain relief. Uh, mm, 10-15% patients they have partial relief and they are able to continue with their day-to-day activities or doesn't hamper their routine work. 10-15% patients they continue having pain. So that is where that they are the most difficult one to counsel. So fair results we can say, sir.
Yeah. Good. So thank you very much. I don't have much to ask because it's a new subject for me also.
Yes,
Good
sir.
that anything new, innovative is good. Scientific, logical, then it is fine. So let's
Yes, sir.
hope it will pick up and it can be tried. But microscope is must. I think what you said is correct. So buying
Yes.
microscope, share the details. Even if you have shared here, a lot of people might have got benefit. Share with me. So
Yes.
there is no problem.